So my name is Katrina and I'm with the Michigan Opioid Collaborative. Today we have Dr. Chris Frank, who's going to present on tobacco use disorder. The Michigan Opioid Collaborative has committed to doing a monthly webinar series, so we hope you'll join us for more webinars in the future. Everyone will be muted during the presentation. If you have any questions, you can put them in the chat box and we'll get to them at the end. Also, if everyone could sign into the chat box with your name and email address so we know who's attending. And if you would like to receive information on future webinars, you can indicate that also. Also, for those of you who would like the social work CEUs, I'll be posting a link in the chat box to the survey. Please complete the survey as soon as possible after the webinar to get credit, and the survey will redirect you to the certificate at the end. And I will also be posting the CME code also. And with that, I will turn it over to Dr. Frank.
Hey, great to see everybody today. I'm Chris Frank. I'm a family physician and addiction medicine person, and I'm a consultant for the Opioid Collaborative. I partly wanted to give a tobacco use disorder talk today to see if actually anybody would come, because I think probably, my guess is the turnout will be low, and I think that's probably illustrates a little bit of what I wanted to talk about today, which was really probably an underemphasis on treating tobacco use, especially in patients with significant mental health issues and other substance use disorders. So we will see. So I want to spend just a few minutes on the epidemiology and diagnosis, although I don't want to beat that dead horse. I think everybody on this call probably understands the impact of tobacco use and nicotine. But I do want to talk about some of the medications and psychosocial options for treating patients with tobacco use disorders. And then I definitely want to focus a little bit on treating patients who have other substance use disorders or other mental health conditions who also have tobacco use. I don't have any conflicts of interest. Here is the activity code, CME stuff, if people would like. You can scan the QR code. I also have it as part of my last slide. So, you know, just really briefly, we can just say that smoking was very, very uncommon before 1900s. And this is really illustrating the fact that tobacco use disorder is a very new thing on the scheme of substance use disorders. You know, has a much shorter history than, you know, opioid use disorder or something like that. So started almost nobody smoking in the 1900s, peaked in the 1960s and 70s. And right around this, this is the famous one, 1964 Surgeon General's report on smoking and health. And then there were a bunch of public health-ish interventions that happened after that around restricting advertising, raising taxes, limiting access in lots of different ways. And we've seen a steady decline in tobacco use since then. Smoking is not evenly distributed across our population. I'm going to talk specifically about patients with significant psychological stress in a little bit, but you could also you can do a very similar thing looking at smoking rates divided by education level or poverty or other socioeconomic indicators. And essentially what we see is the more wealthy you are and higher education you are, the less likely you are to smoke. So this is people with college degrees. And so we see that the tobacco use rate is now, you know, it's really low. It's probably under 5% for that group. Whereas people who have less than a high school education or graduated high school still are up around 20%. So 1 in 5 of people are still using tobacco. There's been a bunch of other good positive things too in these trends. So, you know, about half of adult smokers try to quit in any 1 year, which is up from what it used to be. And then about in any one year, maybe like between 7-8% of people successfully quit. So it's actually, it's a good positive story for treatment of a substance use disorder. I know lots of people are interested in youth vaping, because what we've seen is tobacco use and cigarette smoking among youth is like very, very low. It is like almost, it's almost like an old person thing now. And so vaping is much more common. This is from the 2020 Youth Tobacco Survey. And what we saw, this was like when this 2019 is when people were freaking out about vaping because it was on this huge upward trajectory. And obviously we were seeing the people with acute lung injuries from vaping. But there was some good news in the 2020 youth survey, which was almost 2 million fewer users just in that 1 year period. So pretty dramatic drop in vaping among high risk people, which are youth in general. So like I said, current high schoolers, very few people are even experimenting with some of these less common things. The vast majority is in the e-cigarettes and vaping category. So even though all these good things have happened around tobacco use, it still is always shocking to me how much it impacts health outcomes. So still the #1 preventable cause of early death, both in the United States and around the world. Here's deaths attributable to individual risks in the US. So these are preventable causes of death. And smoking still is the biggest one by far. So almost 500,000 deaths a year attributable to smoking. And then there are, other lifestyle things and high blood pressure in the top tier. And then, we see things like alcohol use down here, and, the other substance uses don't even make the top 10 list. And so I always, in my mind, think about this because I think it's easy to just look past tobacco use and smoking while we're concentrating on maybe more acute substance use disorder or mental health issues that seem more pressing, but don't have the same long-term impact. I know everyone on this call probably knows this, but this is just a little bit of addiction reminder that vulnerability is highly variable by substance. And I know we use this slide a lot because we're often showing opioids down here. So about 25% of people who use heroin will go on to develop an opioid use disorder. And then there's these very low ones like psychedelics, which are maybe 5%. Cannabis, which is about 10%, alcohol, which many of you are very familiar with, around 15% of people will develop an alcohol use disorder. Tobacco is actually probably the highest. And so, almost 30% of people are going to develop a tobacco use disorder, moving from casual use to a more compulsive use. And it's partly because of the impact of nicotine, but it's also very much related to the drug delivery mechanism. And I kind of like this graph just as a reminder because it's relevant to all substance use disorders. When we think about the speed that drugs get delivered to people's brains, it makes a big difference on how reinforcing it is. And so things that get there very fast and then leave very quickly are very reinforcing. And so that's why we have, things that are ingested, like, oral morphine, have fairly low or less addiction potential. And as you move into faster and faster acting things, it has more reinforcing potential. And inhalation is the quickest way to the brain, even stronger injection, even faster than injection. So this kind of explains a lot of the things that we all see, which is that crack cocaine or smoked methamphetamines or tobacco or other vape or smoked products are very reinforcing. People with mental health and other substance use disorders smoke at a much higher rate than other people. So this is an interesting, it's a little bit of an old study, but it still holds true. So a large population survey in Australia and the US. And essentially, this was back when the smoking rate was a little higher than it is now. But, if you had no mental disorder at all, you're in this 20% range. And as you added different other diagnoses, you can see how high the tobacco use rate goes. And obviously that matches a lot of what we see in other substance use treatment centers, where maybe a methadone treatment facility might have a tobacco use rate, in that almost 80 or 90%. But what you see is patients who have alcohol dependence or a substance use disorder are much more likely to use tobacco than people who don't. And there's also a pretty direct correlation, especially among young people, an association or connection between smoking and psychological distress. So on this one, this axis here is a psychological distress score. And what you see is that as people's psychological distress, self-reported stress goes up, their chance of being a tobacco user also is much higher. So I don't want to perseverate on this because I know everyone on here knows a lot about the health consequences of tobacco use, but it's easy to, I partly wanted to give this talk today, partly because I think we'd probably discount it, but partly because I also discount it. And this was like my way of kind of giving myself a little motivation too. I'm in a primary care setting, at least part of the time. And I think it's easy when people have lots of other problems to ignore or push tobacco use to the back burner. But there's actually very few diagnoses that have the same level of risk as tobacco use. Smokers die on average 10 years younger than non-smokers. We know that it increases death rates in all kinds of categories. So coronary artery disease, stroke, lung cancer, COPD, and then all of these other things that I only put on the list just because I find them motivating for some people. It's very, I use the erectile dysfunction one a lot to help motivate some men. A lot of people around dentition or skin health, other things can also be helpful. The interesting thing is that, separate from this, we know that patients with substance use disorders and other mental health conditions also die significantly younger. So anywhere from 5 to 25 years younger than control groups. And it's due to multiple reasons, right? Some of that risk is due to increased rates of suicide, also increased rates of overdoses. But the reality is a huge portion of why patients with other mental health and other substance use disorders die early is due to their tobacco use. So about 2/3 of the difference in life expectancy for patients who have serious substance use disorders or mental health disorders is actually due to tobacco use. I think any of you who were ever smokers probably have lived this tobacco addiction cycle, but I think it's helpful. And what it reminds me of is how weird and reinforcing tobacco smoking is. So in this picture, it's like, so it's time during the day. This is kind of like one day in your life here. And this is a plasma nicotine level here. And what you see is people feel normal when they're in the gray zone. And so what happens is people lose a lot of their tolerance during the night. And in the morning, their first cigarette gives them a very pronounced feeling of arousal or pleasure. And then their nicotine level drops back down to the normal. And then next cigarette, same thing. But what happens is over time, their nicotine level rises during the day, and they get less and less arousal and pleasure, and they get more and more into the withdrawal symptoms between cigarettes. And then at night, this is one of the weird features of nicotine, is that people's tolerance drops down very quickly. And in the morning, it's almost like they started out again. So I think of this actually as like a opioid use disorder, kind of, where people start out and they get euphoric and then they come back to normal, they get euphoric, come back to normal. And then over time they develop tolerance. And instead of getting euphoric, they just feel normal. And then they start to withdraw and they have to use just to get back to normal. I feel like this tobacco addiction cycle is actually like the opioid addiction cycle, just like compressed all into one day. And I think it's one of the reasons that tobacco use can be so difficult for people to get on top of. This is just for reference. Diagnosis of tobacco use disorder, we can say lots of negative things about the DSM-5 criteria for substance use disorders, but one of the good things we can say is that the definition is the same for any substance now. So we can replace tobacco with anything: opioid, alcohol, methamphetamine, cannabis, and then these other things are all the same. So, withdrawal and tolerance being two of the main ones. And then for tobacco, use in larger amounts and longer than intended, and inability to cut down or stop are two of the major ones. And then we see lots of people who also are in the continued use despite physical or psychological problems made worse by use. So that'd be all my patients with COPD who can't stop smoking, even though they're on supplemental oxygen and hospitalized all the time. I had a person the other day tell me, when I asked them if they would like any help with their smoking, and he said to me, "I will stop when I die." One of my favorite acronyms in medicine is this TTFC, this time to first cigarette, because it's like a very simple and easy way to determine people's level of nicotine dependence. And probably some of you have seen this with patients. Most people have to smoke early in the morning. If they need a cigarette within the first 30 minutes, they usually have moderate levels of physical dependence, and they're gonna often have significant withdrawal symptoms if they try to stop. It's obviously a group of people who smoke right away when they get up, and they often have very severe nicotine dependence. There's actually a group of people who wake up in the middle of the night in withdrawal and smoke, and they're in the very highest class. Tobacco withdrawal is vague and uncomfortable, and it overlaps with withdrawal from multiple other drugs and medications. And so it often can complicate management of other substance use disorders because we can't tell what's going on very easily. So it often emerges hours after the last cigarette, and it includes a lot of, irritability, frustration, anxiety, difficulty concentrating, problem sleeping, and then obviously one of the major reasons that some people go back to using is because of this increased appetite or weight gain. And it's prolonged, like we see with some other substances, including alcohol, and it can last for up to 4 weeks, and it's a major cause of return to use. For providers and people who work in treatment settings where they are taking care of patients who also use other medications. I have found this really helpful, and it's something that it took me, I didn't learn for a long time, which is that, tobacco by itself increases the metabolism of a number of other medications and drugs that we use or patients use. The main ones being caffeine. And so, essentially when people smoke, their body metabolizes caffeine a lot more quickly than someone who doesn't. This probably explains why so many people who smoke drink a lot of coffee, because it takes quite a bit of a dose to overcome that metabolism. Same thing with some of the antipsychotic medications that we might see for some of our patients who have really severe mental health disorders. And the reason I bring it up is because when we stop smoking, our body adjusts to this, and you can get a really acute rise in medication doses, and it can cause all kinds of problems, especially around caffeine. So a lot of people who maybe would drink a pot of coffee a day, they'll stop smoking and they'll still drink the same amount of coffee, and they feel really irritable, jumpy, insomnia, abdominal discomfort from heartburn, all of these things. And it often gets blamed, the tobacco use withdrawal is what gets blamed, but sometimes it's actually because they're taking in a lot more caffeine than their body is used to. So it can be helpful to tell patients this so that they cut back on their caffeine consumption while they're trying to stop smoking. It's for people who really have, patients with schizophrenia or schizoaffective disorder who are on clozapine. This can also lead to really high levels of clozapine, which can trigger seizures in some patients. So if we think about what works to help people stop smoking, there are lots of things that help some. There's no magic bullet, and actually I think this is a good reminder because it's very similar to a lot of the other substances that many of us are dealing with. So counseling and giving people money for successfully stopping, so that it's almost like a contingency management type approach that you might see for a stimulant disorder, does work. There are these text message behavioral support programs that also work. We know that the more frequent contact and the longer sessions are, they seem to be a little better. So if you get behavioral health counseling to help you stop smoking, often if you have 6 visits instead of 3, or if the visits are half an hour long instead of 10 minutes long, they'll seem to work better. And when you match behavioral support plus pharmacotherapy is where you seem to get the most bang for your buck. People have tried all different other things, and some of them probably maybe work a little bit, but they don't work great. People have tried competitions. Obviously, motivational interviewing can help to get people to their quit attempt or to move people along on their change continuum. But for the actual quitting, it's been hard to show that it is beneficial. And then real-time video counseling, it's been hard to prove that that's better than other forms of counseling, either by phone or in person. All states have quit lines, and I think many of us kind of know this, but maybe don't, or it took me a long time to know what this actually was, like what patients actually got from it. So it's state funded, it's available everywhere, it does work significantly better than not doing anything. Essentially, you call in, you get an assessment by a tobacco cessation specialist, and then you get a series of 4 motivational follow-up calls. Some states have free nicotine replacement. The one in Michigan offers many languages. So for patients who are struggling with getting interpreter services, it can be a good way to go. And it's really a good choice in some settings where transportation or insurance is a barrier. You know, nicotine replacement therapy works quite well. You know, it doubles people's chances of quitting. I think of it as the methadone of tobacco use disorder. Really, you know, designed to get people to maybe an abstinence type state in a different way than methadone typically is, but it's also a harm reduction approach towards dealing with tobacco dependence. So we know that it increases, it doubles people's quit rates, and that I know a lot of people on the call today are maybe not clinicians, but some are. There's really good evidence that using a combination of short-acting and long-acting nicotine replacement is the best. And so a lot of times what we see is that people struggle with nicotine replacement therapy, and it's often because it's dosed too low or for too short a time. And so the sort of gold standard nicotine replacement is a long-acting thing, so that's a patch usually, and then very frequent use of short-acting, either gum or the sucky candies or the nasal spray or the inhaler at a really frequent rate, so like every hour for the first few weeks. And while the manufacturers and some of the guidelines have people quit or have people stop nicotine replacement or wean after 6 or 8 weeks, it seems very clear that people do better if they continue for at least 3 to 6 months. And we know that preloading probably works, which is where you start nicotine replacement while people are still smoking, and then set a quit date in the future, like a week or 2 down the road, where you actually try to quit. This is mostly for clinicians, but a lot of these are over the counter. Now too. So it can be helpful for really anybody who interacts with patients with tobacco use disorder to kind of understand the dosing, because patients screw it up all the time. And clinicians screw it up all the time too. And so bottom line is that for people who are real smokers, like half pack plus a day, they're going to need the highest dose patch. It's often underdosed. And then for people who need to smoke first thing in the morning, anytime in the first 30 minutes, they're going to have a lot of dependence, and they should really be using the high dose formulations of the sucky candies or the gum. And it's important to tell people how to take the gum, right? People do all kinds of weird stuff, like they chomp it, and then they get like this big burst of nicotine and they feel terrible. It's, you're supposed to chew and park it, or bite and park. So like you chew the thing until you feel the nicotine taste, then you pack it in your cheek or in your gums, and then when it dies off, then you give it another chew, pack it, another chew, pack it, over a half hour. This is just for reference for clinicians. This is my favorite of all time because I can never remember any of the doses or the total numbers, and they differ for like the sucky candies and the gum. Like one you can use 24 pieces a day, one you can only use 20, whatever. It's just for reference, but it can be helpful to look it up so that you make sure that you're using the correct dose. Wanted to take 1 second to talk about e-cigarettes for smoking cessation. I know we talked about vaping earlier a little bit, just in the sense that it's obviously a lot of youth are using it. They're usually not using it for smoking cessation. They're usually using it, mostly flavors. I know a lot of you are seeing this at all ages, probably not just youth, but a lot of people are using it for THC or other nicotine formulations. But e-cigarettes, the ones where you buy like the rechargeable cartridges with a fixed dose of nicotine, those have actually been pretty well studied, especially in Europe. And if they've done some comparisons of e-cigarettes with and without nicotine, and the ones with nicotine replacement do work better for smoking cessation than ones without nicotine. And it does function a little bit like nicotine replacement therapy, and increases people's rate of not using tobacco. I don't have it's not like a hardcore data presentation, but I wanted to talk about one study because I think I have a slide or two about myths around treating patients with tobacco use disorder who have other substance use problems. But I think, you can just say that overall, historically, we've not done a great job of addressing tobacco use in patients with other substance use disorders or significant mental health disorders. And oftentimes we've used ineffective approaches because of fears or unsubstantiated fears about maybe exacerbating mental health issues or worsening other substance use disorders. So this is one of the most famous studies of tobacco cessation. It's called the Eagle study, and it was done. Some of you may know, varenicline, Chantix, had a black box warning early on. And any of you who have ever taken it know that it can make people can have really weird dreams, and pleasant or unpleasant, but weird. And early on, there was a suspicion maybe that for people who were predisposed to severe mental health disorders or had mental health disorders, that maybe varenicline could make those things worse or even trigger suicidal ideation or a suicide attempt. So there's a black box warning, and for years, even when I was training, like we didn't use Chantix in patients with severe mental health disorders because it was kind of like a no-no. This is the big study that was done, really showing that those fears were completely unfounded. So what they did is they took a giant group of people, half of whom were in this non-psychiatric cohort, so it didn't have mental health or other substance use disorders, and they randomized them to all of the different FDA-approved medications. So nicotine replacement therapy, or bupropion, which is Zyban or Wellbutrin, or varenicline, which is Chantix. And what you see is that this is the placebo group here. If you took bupropion or nicotine replacement, it doubled your chance of quitting. And if you took Chantix, varenicline, it almost tripled your chance of quitting. And that while those things got a little worse over time, it kind of held up even as you got into this, half a year, 6-month timeline. Well, then they did the same thing with people with significant psychiatric disorders. So not like sometimes I get anxious before a test. This included schizophrenia, schizoaffective disorder, bipolar disorder, severe co-occurring conditions. And what they found was, even though the quit rates were lower, the pattern held up. So if you give people placebo, they quit, and maybe 10% of people could quit. You could double that rate with these other nicotine replacement, and you could almost triple it with Chantix. And they used this to go back to the FDA, and this is what removed the black box warning from varenicline, from Chantix. And so now this can safely be used even with patients with significant psychiatric comorbidities, and they saw no increased rates of adverse outcomes in those groups, and quit rates that, while they're lower than people without mental health disorders, are still much higher with these FDA-approved medications. Just for anyone who's like a pharmacology connoisseur, varenicline is the so nicotine replacement is the methadone of tobacco use disorder. Straight replacement, full agonist. Varenicline is buprenorphine. So varenicline is a partial agonist at the nicotinic acid receptor. So anyways, varenicline is the same as bupropion, and they have similar pharmacology. So tobacco cessation during treatment of other SUDs is, we've done not a good job on this. And there's lots of reasons for it. Some of them are historical, you know, but what we can say is that even now, the majority of behavioral health treatment facilities don't offer nicotine replacement. Similar with substance use disorder treatment facilities, and that only about 1 in 5 offer the non-nicotine cessation medications. So this would be bupropion and varenicline. And, you know, there's a long history of, you know, the tobacco companies, you know, pushing their products inside treatment facilities in ways that weren't always helpful for patients. But the other, you know, there are some myths on the next slide, but we know that for many patients, actually smoking cessation can have a positive effect on other substance use outcomes, including decreasing risky use. And that nicotine and opioids kind of work in a similar pathway and end up being mutually reinforcing. And there's some evidence that actually nicotine cessation is associated with more prolonged low risk or abstinence of opioids, or maintaining treatment for patients who are on agonists or partial agonists. The myths, I think, are pretty common. Essentially, you know, I think there are still people who talk about maybe that if you get smoking cessation treatment, somehow that can jeopardize substance use recovery. It's the whole idea that that patients with substance use disorders maybe need to self-medicate with nicotine, and that's the thing that allows them to maintain other aspects of their recovery. And that does not seem to be true at all. It actually seems to be the other way around. There's also sort of thoughts that maybe patients with behavioral health issues or other substance use stuff are unable to or unwilling to quit. And that is not true either. Surveys of current patients with those other conditions, often patients do express a desire to quit. They're often willing to try. They often need slightly more support than other people, and they quit at a lower rate. But the medications really do work in the same way and get similar effect sizes. So, you know, double or even triple people's rate of quitting. And then obviously there's a common misperception that tobacco use makes other SUDs easier to manage, and that on big population level doesn't seem to be true. Obviously, it's hard to quit any of these, and obviously the addiction prevalence data I showed shows that tobacco is one of the really difficult ones. But what I really wanted to just leave you with was the idea that, you know, a lot of the long-term decrease life expectancy in patients with substance use disorders and severe behavioral health conditions actually comes from their tobacco use. That the medications that we use for tobacco use work and are safe, and work in some of the most challenging patients that we see, and that we shouldn't ignore this just to focus on other things, even though I know even though tobacco use disorder is not sexy, and you know, none of us really like dealing with it because it's like feels like it's just there. But I think sometimes focusing on tobacco cessation can help support people's recovery in other areas, and can be another opportunity to provide harm reduction services, either through nicotine replacement, long-term medications for tobacco use disorder, and supporting their other parts of their recovery. So that's my last slide. I put up the QR code again, and we can do any questions, comments, and if we end a little early, that's great too. So thanks everybody, and anyone feel free to pop something in the chat. Let me see. Do you know if the time to first use correlation to severity of SUD is true for THC as well? Oh, that's a good question. Yeah, all the people who smoke or all the people who use THC in the morning for their nausea and make their anxiety worse. So the short answer is, like, I don't have like a good slide that shows this, but the tolerance and withdrawal that people get from THC is not the same as nicotine. Works in a different, the cannabinoid pathway, and it doesn't seem to like flip in the same way that nicotine does, like really fast. So I don't think of it the same way, but I also don't think like people really know at that level. I don't know if people smoke in the morning right when they get up. I don't know if that's for withdrawal or it's this cannabinoid, this hyperemesis type syndrome, which I guess could be just withdrawal. So I don't know if you have any thoughts on it, or anybody else has any thoughts. I'd be curious to hear. Anything else people can think of?
Hyperemesis syndrome was something related to withdrawal, but I can't remember. That was during the ACM conference. I honestly can't remember who said that. So I have a question. Do you ever use the Michigan tobacco hotline? Like there's like a helpline or hotline or something?
Yeah, it's so obviously, the quit line is great, and that has a lot of those services. And then probably many of you have your own internal, like we have like a M Healthy, which does like internal tobacco cessation counseling. So almost every health system has their own thing too. And a lot of times you can double dip. So patients who need extra support can do both. The difficult part is for patients who have Medicaid or maybe don't qualify for services in different systems, and then the state helpline is really helpful. So Yasmin asked, do you feel the decline of smoking is due to education or other factors? Personally, I think that probably nothing feels like education, but public health people would point to tobacco as one of the best examples of population level public health interventions. So when World Health Organization and CDC have studied tobacco use, the things that have had the largest effect sizes are restrictions on advertising, removal of access, so removal of vending machines, raising the tobacco age from 18 to 21 in the states that have done that. And then obviously, one of the most important things has been just the overall societal changes around the acceptability of tobacco use, and the biggest one being smoke-free buildings, workplaces, restaurants, bars. Some of you are probably old enough. I mean, some of you are obviously old enough to remember, like when they were talking about taking tobacco out of restaurants, and everybody's like up in arms, like no one's ever going to go to a bar again. No one will go to a restaurant. And obviously that was completely not true, but it completely changed the cultural expectations around tobacco use. So actually, I don't think the medications have helped some, but it's been mostly those public health interventions that have decreased it. Oh, sorry, I actually just went on to a slide that I used for a different talk, but it is good to know for those of you who treat pregnant women or women of childbearing age, nicotine itself is teratogenic. And so while most of the, mostly we just like think of tobacco as all the bad stuff. So, all the particulates, and all the carbon monoxide and all the lead and cadmium and all the other crap that's in tobacco smoke. And then nicotine, for the most part, it's the addictive part or habit forming part, but it doesn't really have a lot of negative health impacts on its own, right? It doesn't really cause, doesn't cause coronary artery disease. It doesn't cause increased stroke or these other things. It's why nicotine replacement therapy is very safe and you can use it for a really long time and people's rates of all those other bad things go down. But for people who might be pregnant or going to be pregnant, nicotine itself has a teratogenic capacity. So birth defects and some of the things we see in the immediate post-delivery period, like SIDS, sudden infant death syndrome. Oops. Any other comments, questions? Has anyone else figured this out? Like, does someone have like if someone has a magic bullet, they should definitely unmute themselves and share it with the rest of us. But there's actually not that many things we do where we triple someone's rate of either stopping something or improving their health outcomes in the same way. Varenicline is underutilized for patients with other SUDs and other mental health conditions. Oh, Tim asked, what are my thoughts regarding the language nicotine replacement therapy? With opioids, we typically advocate against the directly analogous opioid replacement therapy. Yeah, I think it's a good question, Tim. And it's obviously so regional, right? Europe still would call methadone, opioid substitution therapy. And I think it's very accurate description of what it is, right? But it's so stigmatized that we've had to come up with all of these machinations to try to destigmatize some of the language. I just don't think nicotine is stigmatized in the same way. So I don't think it matters much for nicotine, but I do get your drift. I think it's super interesting how we've had to go through all the rigmarole around opioid naming conventions to try to destigmatize things instead of using clear language about what we're doing. Well, if there are no other questions, everyone's got a few extra minutes, and I wanted to thank everyone for attending today. Everyone who is here, I give you a lot of credit because I think people see tobacco use and they don't want to go to that talk. And I wanted to test it, and I'm really appreciative that some of you are still having your eyes on the full picture. And it's great to have everybody here. And we look forward to seeing you for the next webinar from the Opioid Collaborative.